We'll move quickly through this. I'm going to talk about Indian Health Information Network Development, acronym IHIND. I work in rural India. This is one of the areas we work in, and also work in high-tech tertiary care US hospitals. So somewhere I spend almost half time in each place. I was just in village UP just before I came here the last week. So when in the morning when I hear a whole lot of hype about telehealth, I always wonder what country are we talking about. This is my telehealth. She's a trained health worker by us. This is her telehealth. She goes from house to house delivering health care, and it's been pretty successful. We reduced maternal mortality by 93% in 1,000 villages. It has been picked up by UNICEF and Bill Gates Foundation. We did only 2 districts. They've done 39 districts now, and at a minimum cost, and guess what, without IT. So there's a portion that wisdom also is applicable in medical care besides technology, and also work in this area too. What is this IHIND? It's to create a national interoperable health information network to enable various stakeholders to have access to healthcare information. You can go on prolong this, but this is in brief, which we all understand. It was started with the National Knowledge Commission Group. It was something 2007 or so, chaired by Dr. Ganguly, with a lot of luminaries there. And then it went on to form under Ministry of Health and Family Welfare, and I was again facilitating the whole thing, and these are international experts from various countries, and we had all the people who had contributed to things, including from NIC, and as one of the pioneers in medical informatics, who's got his PhD, something like 72 or something, in health informatics, Sweden, and et cetera, et cetera. A lot of good people. Now, what does this really mean? What we're talking about is this. We have a few objectives. IHIND is, of course, improve quality, healthcare, finance, and technology. How do you finance healthcare? Big issue, insurance, RSBY, et cetera. Secure access to data and command, reduce duplication, process reengineering, fraud and abuse prevention, public health planning, drug surveillance. Of course, you can make bigger, deeper silos in there and sub-functions and so on. It's an ad infinitum, it can go forever. And this will form a national network. Stakeholders, every person that you can think in healthcare is a stakeholder, including the dispenser, the druggist, the chemist, the ambulance operator person, etc. So anybody should be part of this network. Then only you will have people who are principal secretaries be able to plan the whole thing in a holistic manner, as opposed to little silos here and there. This is a dream. It's possible only because we have ICT. It's not possible without. We can, and it's so eminently doable. You can really roll out the process in the next 6 months. It's so easily to be done. I'm a physician. If I can think that way, the ICT people would say it's only 3 months, not even 6 months. In the value chain of healthcare, we have enablers with policy, regulation, health, finance, ICT people. We have developers, industry, academia, and R&D labs. We have providers, hospital, ancillary personnel. We have consumers, health literacy, paying abilities, civil organization, etc. Everybody's part of the health chain. So we're saying all these stakeholders have something to say or something to consume and something to provide in this healthcare IHIND network. Now, how do you talk to each other? Of course, we had to have interoperability standard. If you talk in Malayalam and I talk in Kashmiri, we can't communicate. So let's agree nationally on what our operable standards are, and that will be the part of integration that our principal secretary was talking about. That these are now 15 years ago approximately, when I was working in this area, we did not have interoperability standards. I had to guess that SNOMED is going to be winner at that time, and I pat myself on the back that I was right. I didn't know that. I was just guessing, because we started a company. All right, let's start a company. What's the futurist company? What is going to go? We said, let's go for SNOMED. Incidentally, Mayo Clinic uses a language called medicine. And they also, in a well-meaning system, said we're going to offer medicine, and it is a failure. So it's not that all well-meaning steps can be correct, but this is at the moment accepted international standard. So my suggestion is, anybody's developing anything now, please stick with this. Otherwise, you'll be redundant, useless, or maybe you'll be in a silo, won't talk to anybody. This is the vocabulary. Communication protocols is the one we use. Content exchange, HL7, Professor Saptan is here. Oh, he's here. He's the chairman of India's HL7 protocol. Can you stand up, please? These are pioneers we must respect. These are pioneers that have taught us. His incident is doctor and health IT PhD. And of course, it goes to HL 2.5, and all the academicians will argue which one is better. They kill each other on this. We ignore them. And DICOM. And then security is extremely important. That finally, how do I keep my patients' data private who's suffering from HIV/AIDS? How do we do this? So this is extremely important. And this also has been, the bankers and the defense people who have already done it as a group captain, you know that they can keep security. So health data is not very difficult. So the thing is, it has been solved already. And that's why I say it won't take much longer. Now what are we talking about? We say we should have this kind of hub and spoke model. You have each district, 620-some districts. Each has its own IHIN. It's connected to the state, and state is connected to the center. Hub and spoke, age-old model, nothing extraordinary. The architecture will be at a state level and also at a center level and the district level. This is the hub. All the stakeholders feed into this. And from that stakeholder with a secure wall, need-based access to people who want it. The government health department wants the government health data, you get it. Insurance provide only the financial data. They don't need to know many other things. Research wants some particular things, surveillance, epidemiology. So it's a need-based access. You cut and slice the data into need-based access and provide it to them. And my dream is that this may become even a revenue-neutral model, because some people will pay for that sliced data, which is anonymous data. Again, keeping the privacy in place, this could become a revenue-neutral model, maybe even a little positive cash flow here. And this is a regular run-of-the-mill old process gone electronic now. This is nothing extraordinary about it. And this is the minimum data elements that should be there. There should be demographics, clinical data, and unique identifiers, but there should be UID, UHID, and a medical record number, etc. We had to create them. Now, I've just taken the slide from Canada Health Info, who are far ahead of the, at least of the moderate-sized countries. There's a point of service applications, and they have what I call this HIAL or Health Info Access Layer. And they have a longitudinal record services, which is what we call the EHR. The difference between EMR and EHR is EMR is what's a hospital-based medical record. EHR is your birth-to-death health record. So that's a kind of a nomenclature difference. So we need to have EHR. Otherwise, our health department cannot plan. EMR is okay for the hospital, but EHR is needed from birth to death to see what happens. And then we have this EHR locator, and they have the registry EHR data services, info data, ancillary data services. This is how they design it, Canada Health Info way. Then we need a policy framework, which is that the key is who's going to own this data, and who's going to control the flow of data. Now, it's a massive data. Who owns it? Does the patient own it? Hospital owns it? Doctor owns it? Well, ethically, it's the patient that owns it. Everybody agrees the patient should own the data. But how do we keep the privacy and security, and how do we ensure? So there's a storage and admin problems, storage of data, confidentiality, access problems. Now, these all have been solved. It is not that this is the first time we're thinking about it. So that's why it's so easy to do. This was a recommendation to them from both NKC and from the Ministry of Health, that you should be kind of autonomous like the Telephone Regulatory Authority of India, adequately funded and a neutral organization, and hopefully will become not dependent on. Now we had suggested, this is, we presented this to Ministry of Health on 16th of April last year. And Health Minister Honorable Azad was there, and Minister of State Dinesh Trivedi, the whole health ministry was there on that particular day. It was well accepted, and I'll tell you what has happened to it later. Pre-pilot, we suggested, then let's say to do a pilot phase, 2 districts, implementation, do it 11, 18 months. then we say national rollout, etc. And the good news is Gujarat has taken the lead, so maybe we should adopt Gujarat model for the rest of the country. Why reinvent the wheel? There's no use, redoing everything. This was kind of a thing, and we said 20-year plan. It's not there's no rush in doing it in 10 years or 5 years, but let's do it right, and let's do it in a futuristic manner so we don't have to revamp the system. Now, I want to give you a comparison of what I'm talking about. We have an advantage in India that we have no legacy system. So there's nothing to dismantle. I work in US, I work with Cerner system, I work with GE system, I work with the Henry Schein system. The problem is that the three don't talk to each other. And the silos are so tight now that Blue Cross Insurance Company does not want to talk to Aetna Insurance Company because there's a business. Why should they talk? So we said, since we have nothing here, and before they wake up, before Apollo says, I will not talk to Narayan, Hidralaya, let's tell them, please talk to each other now. We have common platforms. Because once they get entrenched, trust me, healthcare is beyond repair. I live in a country where it's beyond repair, that's the US. And let's not go there. And I can warn you right now, India is going the US way. US, what was in 1960, India is right now. Anybody has got time, I'll explain to you what I mean. And we're going unknowingly the same path, and we'll be there in 40 years and we'll regret. Now, this is the implementation. You saw that. Compare it with USA IT Strategic Plan Update. We presented, NKC met in 7, 8 or something, we did work. Then last year we presented to the Ministry of Health. In the meantime, US decided in 2009 we're going to do it. And guess what? Right here, we already have it. It's already penetrated right to the doctor's office level. Now, where's the problem? The problem is we suffer from implementation deficit, and therefore we need leadership, stakeholder buy-in, funding, adaptation as fast as we can. Otherwise, we'll be left. Not that we are the only country that has this problem. Canada had the same problem. So they created this framework, National Change Management Framework. Say we should have a governance and leadership, we should have monitoring, evaluation, communications, training, education, workflow, stakeholder engagement, and they're using this tool to roll this countrywide. The same problem is facing everywhere. Now, this is the area we work in. I work in, this is an old slide. I work in this area here. And what we did now, since somebody's got to do it, we are rolling out our own small IT system in rural India. We have 16 clinics there, which are 16 clinics, because by the time this penetrates from Delhi to rural UP, it'll be 2 more generations gone. And so we said, let's start bottom up. Can we solve the problem? And luckily we have collaborators, IAMI, CDAC, where is SIS here? Yeah, so Gujarat company, Asiad Foundation, which is Narayan Hidralaya, and this is the foundation that my group works in. So we're working together because if we have as a foundation, we have the ability to go 1 village a day. This is the capacity my group has at the moment. But I figured out it'll take me 1,643 years to save this woman's children. She lost 7 children. This girl has lost 7 children. By this method, it'll take me this much time. So it's quite obvious to me the ICT is the way. And there's no other way except develop a national health system if we really want to get into health work and do some good work. Thank you.